Thank you very much, and thanks to the TVS for inviting me over to beautiful Wales on this beautiful sunny day, and I'm so glad that you're all in here with me and not outside in the sun, because I'd be fiercely lonely if I was here on my own and you were all getting lovely suntans. So I've been asked to talk to you about repositioning for preventing and treating pressure ulcers. So what I thought I would talk about is, I'll ask the question, why are we repositioning? Who are we repositioning? How are we doing it? And what is the impact of what we're doing? So as you know, and we have this definition everywhere we go, we carry it on our backs. It's, I actually have a tattoo along my bum. I don't really, but actually it would fit on my bum, but that'll be a problem, all right? But anyway, the idea is that if we look at this definition and we clearly understand this definition, it should make sense to us. We talked outside at the stands there about getting back to basics. I mean, if we understand exactly what the problem is, then it should make logical sense to us how we would be able to alleviate that problem. So if there's water pouring down on your ceiling at home, clearly you have a leak, yeah? So clearly we kind of understand that because we can see what the evidence is in front of us. So we know that a pressure ulcer is a localised injury to the skin and or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. The challenge for us is that there are a number of contributing or confounding factors, and we don't really understand all of these. Yet we have been talking about pressure ulcers since the time of Methuselah, and we're still here talking about it. But we are moving forward in terms of increasing our understanding time over time. And it is important for us to remember that pressure is equal to force divided by area. And that might sound grand. When my daughter was doing her junior cert, as we call it in Ireland, I was so excited by her science book. Look, they're talking about this. She thought her mother was, boring. But the reality of it is that if we understand this, then we can see that when we're taking care of patients, why is it that in the study from Wales, your national study, most pressure ulcers are on the sacrum? This concept is directly linked to that, because patients are not evenly protected across all areas of their body when we place them on the most highfalutin mattress known to man, because pressure is equal to force divided by area. And then the question about paediatrics and medical device related injuries comes into vogue here, because pressure is force divided by area. Ask any child outside there in Cardiff, what if I had a child with a medical device that was causing a problem on their skin, what do you think we should do? They would say, move the medical device, remove the medical device, change it, do something about it. They wouldn't necessarily say, I'll tell you what you'll do, develop a lovely new risk assessment tool that's going to say only for medical devices, because now remember, you've got your backpack on your back as you're going on the ward, and you've got all these risk assessment tools you're going to have to use. And what we really want to know is what's wrong with the patient and what can we do about it. So it has to make logical sense what we're doing. And then, as you know, shear, this is kind of highfalutin. If you met me at a party on Saturday night and I said to you over the drinks table, do you know that shear is the mechanical stress acting parallel to the plane of interest? You would say, fair enough, and off you'd go. But the reality of it is, what does that mean for us? And we can visualise in our mind's eye, and if you're teaching patients and they're living in the community at home, and you're trying to get them to understand the importance of positioning and seating, well, when you're able to explain to them, do you know how you're sitting upright, lovely? My father was a teacher, and he used to come into the classroom every morning. He'd say, up straightly, and we'd all sit up straightly. And where were we like 10 minutes later? Flopping down. So if we could explain this to patients and say, look, it's not just about repositioning yourself, it's not just about having this beautiful chair, it's about you being able to be stable and comfortable in that position. And once we can achieve that, then we will help you enormously. And from a wound healing perspective, Keith Harding always talks to us about this slide. And so when you think about the wound healing process, it's so important that everything gets switched on and switched off accordingly, because if it doesn't, the next phase of wound healing doesn't get called in. And I never fully understood that until I went to Cardiff, to the Wound Healing Research Institute. There's Sam down there. And I fully understand the importance that wound healing has to take place in the way that it's supposed to do. And isn't the body amazing that it is able to repair itself? But it needs help to do that. And if I present to you with something like pressure that occludes the blood supply to my wound, how can my wound heal? So repositioning is important for both prevention and treatment. So why do we reposition? Well, we reposition an individual to reduce the duration, so the time, and the magnitude of pressure over the vulnerable areas of the body. And in keeping with the lecture just before me, it's also to contribute to comfort, hygiene, dignity, and functional ability. Now, oftentimes we only think about pressure ulcer prevention. We don't think about the person per se. And even if you had a magic mattress, do you know what I mean? Really, really magic. I would be fiercely lonely, I can just tell you, if you left me there for 12 hours on this magic mattress and you never came near me. Because for my own health and well-being and my quality of life, we need contact with each other. And therefore, that's important for patients as well. And don't forget that in our just being there, communicating with them, touching the person, saying, I'm here for you. Yes, I understand what's going on, and I'm doing my level best with you to try to help the circumstance. So who are we going to reposition? So in our guidelines, our international guidelines tell us that we reposition all individuals at risk of or with existing pressure ulcers unless contraindicated. The strength of evidence is A, and the strength of the recommendation, 2 thumbs up, you should definitely do this. So just to remind us about the strength of evidence, so A is by direct scientific evidence, B is from maybe not quite the same strength of evidence from your double-blind randomised controlled trial that's got through meta-analysis, but nonetheless we have scientific evidence for it, and C is from indirect evidence. So who? So in one study that we did in Ireland, where there were 1,100 patients and 1 person doing the study, we had 53.5% of the patients in 12 long-stay settings required repositioning if you looked at their Braden mobility scores. That would equate to 58.8 hours of nurse time per night, because we were just thinking of the night time at that moment, and it's equivalent to approximately 12 full-time nurses or carers who are able to do the repositioning and who are able to assess the skin and interpret what's happening with the patient's skin when they're evaluating the patient. The cost is about €200 to €250 per patient over a 4-week period, and the annual nurse time cost would have been €2.1 million. So we need to think carefully. Yes, we know it is important, but for value for money, for return on your investment, you want to be sure you're giving it to those who require it. So Sheboyer did a study where they looked at the 24-hour physical activity patterns of hospitalised patients at risk of pressure ulcers. Each participant wore an activity monitor continuously for 24 hours. And on average, the patients changed their position just over 90 times, which reflected 3.8 times per hour. They were unable to tell the extent that the patient moved themselves or how much movement was actually initiated by nursing staff. So they were able to identify for us that patients do move and sometimes move independently. Another study by Coleman, she had 52 patients who were registered continuously using a monitoring system, and the nursing staff documented each time they repositioned the patient. So we had better information, the patient's independent movement and when we went in and did something with the patient. So they compared the patient's spontaneous movements with nursing staff-induced repositioning. And there were large variations, as you would imagine, in patient spontaneous repositioning frequency during day and night. So some of us are like sloths, that's me, don't move hardly at all. And there are others who are like marathon runners and who are continuously twitching and moving. So although immobilized, so they are categorized as being immobilized, some patients frequently repositioned themselves. As you could imagine, analgesics were positively related to movement frequency. So if I am in pain, what am I going to do? Stay rock still. If I'm not in pain, I'm going to be more comfortable to move around. And as you could also imagine, psycholeptics were negatively related. So the more you sedate me, the more unlikely I am to move myself. So the nursing staff most often repositioned the patients who were assessed as high risk rather than those who were assessed as low risk. Now think about your clinical judgment here as well. Do you know what I mean? If I don't have much clinical judgment, I'm going to rely on what the tool is telling me, 100%. But the patient's spontaneous movement frequency was not correlated to the risk score. So that's a bit of a worry, isn't it? And indeed, one of my own PhD students at Glazy is doing a study at the moment where she is looking at movement as well. And 2 patients that she had, both were scored as being, medium risk. But one of the patients actually made 0 movements in the night time themselves at all. Now, clearly, if you're thinking about pressure ulcer development, if the patient makes 0 movements, then they really are not at medium risk, whatever medium risk means anyway to us. They are at high risk because they're not moving a muscle. And then Latimer did a study where they looked at 241 participants, and 66.4 were able to move themselves in bed, either independently or with the assistance of bed mechanics. Participants moved once every 1.7 hours, but not necessarily into good pressure ulcer prevention positions. Now, you could reflect on that. How often have you found the patient in the position you didn't want them to be in the first place? And interestingly, older patients, as you can imagine, and males for some reason or another, were repositioned less frequently. So was it that we're kind of thinking we don't need to disturb them or something, or we don't want to upset them, we want to leave them alone? But it's interesting. So it's not necessarily related to their risk status. So clearly, when we're looking at risk factors, pressure and shear, as you know, as we said in the definition, are the prime causes of pressure ulcers. And immobility is the factor that's going to expose me to pressure and shear. And then all of the other factors come in enormously importantly, influencing my tolerance to immobility. So how long can I actually tolerate it for? So it makes sense to us that when you're thinking about it, you really need to focus on those who aren't able to move themselves. But the question is, how do we actually identify that? In the real world, we're not going to be sitting back like our colleague way back in the early 80s, where he counted the number of movements the older person did at night time by just observing them and using a clicker. Could you imagine you doing that? Could you imagine doing it in Wales with all those people? You'd never get it done. We'd be winning the rugby hands down, unbeknownst to yourselves. So then how are we going to reposition them? So our guidelines tell us that we should use the 30-degree tilt, side-lying position, alternating right, back, left, right, back, etc., or the prone position if the individual can tolerate it and his or her medical condition allows it. So the strength of evidence is C, and the strength of the recommendation is that you probably should do it. Not definitely, just probably. And also, you determine the repositioning frequency considering the individual's tissue tolerance, their level of activity and mobility. So in terms of tissue tolerance, how are we determining tissue tolerance? Are we waiting until the person has a break on their skin to say, whoops-a-daisy, we need to reposition more frequently? Or are we going to use smarter technology, which is going to enable us to understand individually for that patient how they are responding to immobility? General medical condition, of course, and in terms of the quote from your colleague you mentioned earlier about people living at home and dying at home, perhaps our sort of care plan is altering into a different mode of care because we want to reduce pain and enhance quality of life, but we are agreeing that together. We're not just doing it without documenting it. Skin condition and comfort, of course. So the strength of the evidence is C, but the recommendation says you definitely should do this. So there were bedridden patients at risk of pressure ulcers, had their perisacral skin-bed interface pressures recorded every 30 seconds while they received routine repositioning care for 4 to 6 hours. 13 patients were observed in 3 distinct positions: supine, turned left, turned right, and all had specific skin areas that exceeded pressure thresholds for greater than 95% of the observational period. So at-risk patients, according to them, I know it's a small study, but they're suggesting to us that they may well always have areas of their body that are actually still at risk. So if you think about back to now, I know I'm a lot older than most of you here in the room, but if you think about when you were trained, I was never, ever taught how to position a patient and how to do that effectively. So maybe that this study is showing us that. We can't assume that we know how to do it. our physiotherapy colleagues would shoot us, because at the end of the day, that's what their whole life's work is about. And we collaboratively should be working together to understand that. Because healthcare professionals are unaware of the actual tissue-relieving effectiveness or lack thereof of repositioning interventions, and which might partially explain why pressure ulcer mitigated strategies are not always successful. So if we don't really know what we're doing, what are we doing? We don't really know. So what's the impact? So there are a number of studies here. I'm going to synthesize them all into one slide for you. So Trudy Young, she looked at the 30-degree tilt versus the 90-degree lateral rotation. Elderly patients over a 24-hour period, 39 patients, and 3 of the patients got non-blanchable erythema in the 30-degree group and 2 got it in the 90-degree group. Tom DeFleur did a cluster randomised control trial with 2-hourly, 3-hourly, 4-hourly, 6-hourly and standard care, 4-week follow-up. Some were nursed on ordinary mattresses, now long time before us, so the standard foam is nothing like we have now, and some were nursed on viscoelastic foam. 838 people, and he found that the incidence of non-blanchable erythema was not different between the groups, but the incidence of grade 2 and above in the 4-hourly group was 3%, compared with other groups 14% and 24%. So he suggested, listen, maybe turning more often is going to make a difference. So that's when Katrien went ahead, Katrien van der Wee in 2006. She did 2-hourly lateral and 4-hourly supine versus 4-hourly lateral, 4-hourly supine. And she had elderly patients with non-blanchable erythema, 235, and she found no statistically significant difference between the groups. Rich then did a chart review, and interestingly found in higher risk patients, the incidence of pressure ulcers was lower for those repositioned frequently. But in lower risk patients, the incidence of pressure ulcer was higher when they were repositioned more, which makes no total sense at all. Myself did a study looking at the 30-degree side, 30-degree versus 90-degree, because 90-degree is what they were always doing in care in Ireland in older person services. And in Ireland in older person services, they were changing their position every 6 hours. That was normal, natural for them. I didn't interfere with that. But in the 30-degree group, we changed them every 3 hours. So you can see that we had 3% versus 11%. Still in her study, had 15% versus 5%. Bergestrom, she found that the incidence of pressure ulcers between high and moderate risk groups wasn't any different. And Manzano found that there was a pressure ulcers of grade 2 developed in 10.3% of patients turned every 2 hours and 13% for those who were turned every 4 hours. So we put all of these together on a forest plot. What you can see in the red at the bottom is that there's 235 people out of 1,364 developed a pressure ulcer in the experimental group, more frequent repositioning, versus 531 out of 1,760 in the less frequent repositioning. The odds ratio is 0.55, and it's statistically significantly different. So repositioning more frequently when you put the studies together makes a difference in terms of the number of pressure ulcers. But I am going to point out that the I-squared is 56%, suggesting that these studies are not necessarily homogeneous. And what we really need to do is try to get some more homogeneity in our study design so that we can make more definitive answers. But it gives us some encouragement that more frequent repositioning will be better. From the Cochrane, she only included Trudy's study, my study and Tom's study, the studies of 502 people, and really couldn't make any firm conclusions. For repositioning for treating, we found no randomised controlled trials at all, no clinical control trials, no trials at all have been done on repositioning for treating pressure ulcers. But what about reposition? How does it feel? I'm running out of time, so I'll speed up here. But basically, patients seem to understand that repositioning is important, but they want it for the patient down the road, not for them themselves often. And when we use repositioning devices that actually turn people spontaneously, we just have to spend some time with the people, making sure that they feel secure and comfortable before you would kind of walk off and let the device do its work. And the key things that we need to think about are stability, comfort and security in terms of our positioning. And the challenges with the evidence is lots of different designs. Some are not analysing for the effects of clustering. Some are using alternating mattresses and low air loss mattresses, some are not. So we need to actually move forward in a much more homogenous way to be able to say, can we definitively answer the question now about repositioning? But nonetheless, it is an opportunity for us, and an organisation like this is full of opportunities. So the Tissue Viability Society is now going to conduct the largest randomised control trial ever on repositioning, and we in Ireland will help you out. Thank you very much. Okay.